Dr. Matsen, you're on, sir.
Thanks. In the most recent JBJS, I stepped out my usual character and wrote an article on malpractice. So I'm going to be interested in your takes on it, and then if you have comments, I really would welcome whether this kind of information is useful, because I've got several others coming down the line here. But take a look at it, and it's called Lessons Learned, and it's in the Orthopaedic Forum. Has anybody had a chance to at least notice it there? So I'm going to have some introductory slides, and then we're just going to sit around and talk, and I'm going to probably prevail on some of you to be a secretary. I'll probably start out with you, Deb. So get your penmanship ready. One of the things that you're all aware of is that we spend a lot of money in the United States on healthcare. And so this is total expenditures on healthcare per capita, corrected for United States dollars, and this is the average life expectancy. And you can see there are a whole lot of countries over here, and then we're over there. So it seems like we're spending a lot of money, and if you believe that life expectancy is a reasonable metric for how well we're doing, it doesn't seem like we're getting the same value, and value is something I'll come back to at the end of our discussion here. You might be thinking as we're going along about what value means. And you all know that with the sequester, there's going to be a cut in healthcare dollars available for us. And here is a little slide that I prepared for you. This is the percentage of gross domestic product down here, and this is the year, and this is healthcare costs going up, reasonably linear, and they're expected to be 1/5 of the GDP by 2021. Hopefully a number of you will be in practice by that time. So anyway, you can see that that's a pretty dramatic trend, and that means we're spending more and more stuff on healthcare, and that leaves less and less for other things. So the question is, where are all the dollars going, and what is the evidence that they're well spent? So one of the papers that we wrote with some of your help is trying to figure out, are we spending money on the right things? And this is in my little shoulder world, but it sort of is an example. So we went to the literature and we found the rates of acromioplasty seem to be going up pretty much linearly with time, regardless of whether you looked at Florida or New York or Medicare, or even in the clinic, in the county that has the Mayo Clinic in it. And also if you look at the data on the top, there was a 240% increase in the number of acromioplasties performed per candidate for the ABOS. Obviously I put one too many zeros there and got that wrong. I think that should be 2003. And it had risen from 9th to 2nd place among the CPT codes of Part 2 candidates. In other words, it was the second most common operation done by everybody that went to take their boards. So then the question is that a good operation? So we came along with this article on looking at the evidence in the literature about whether acromioplasty was supported by the literature. And we looked at 5 different hypotheses, and one of them was successful treatment of the impingement syndrome requires surgical alteration of the acromion and or coracoacromial arch, and looked at all the literature we could find, and there was really no support for the idea that acromioplasty was helpful for treating this thing that people call the impingement syndrome. So again, you've got a rising trend, second most common operation, but not a lot of data supporting it. Now, let's move to rotator cuffs for a little bit, and I think you are all aware of the fact that the Academy came out with what they called practice guidelines for the management of rotator cuff disorders. And Ken Yamaguchi wrote this article about it, and he pointed out that there's some, I can't quite understand the difference between these two numbers, but anyway, something like 200,000 to 400,000 Americans have surgery related to the rotator cuff each year. And if you look at this paper, it talks about the cost of each one of these. So remember, let's just pick a middle number, like 400,000 rotator cuff operations per year. And then the cost of them is, and you see hospital physician total, around 10,000. So who can do the math of multiplying those two numbers? Dan? 400,000 times 10,000.
A lot of zeros.
How many? How many? Come on. Who's good with math? Want to pull out a pencil and a piece of paper?
5 zeros and 5 zeros is 4 million. 4 billion zeros.
$4 billion. Okay? Now, so the first question he says, wow, that's a big number. The second thing is this the total cost of rotator cuff repair? I mean, if you're going to repair my rotator cuff, what else is going to happen?
Can't work.
Can't work. Good. How long can I not work?
6 weeks.
Depends on your job.
Depends on my job. I've got a rotator cuff tear, as some of you know. I decided not to have it operated on because when I went to my doctor, he said, well, you couldn't go back to orthopedic surgery for 3 months. That's costly. Now, but we haven't even talked about PT or imaging or any of that other stuff. So this is a lowball number. So we got 4 billion, right? And so the question then is, if we go back to these practice guidelines, how much is the idea of rotator cuff repair supported in the literature? So I did the math pretty much the same way you did. Anybody know about the Cochrane summaries? You heard of those? So it's where you look to find out if people have done research to find out what's really supported. So I don't know if you can read this, but I like this bottom line here. There was not enough information in the included studies to tell whether surgery would make a difference in the ability to use your shoulder normally, your quality of life, your shoulder's range of motion, your strength, the chance that your symptoms might come back, the time it takes to return to work or sports, or whether people are satisfied with surgery. Now, if that isn't a compelling argument for doing rotator cuff repair, I've never heard one. And they say, research in the effectiveness of surgery, the review shows surgery may not lead to any difference in pain compared with different exercise programs. Now, so then we had this very illustrious group of people looking to form practice guidelines. I don't know if you know any of these people. Adowitz, Ahmad, Yamaguchi, Burks, Flatow, Andrew Green, so on and so forth. So all these great minds came together and they looked at the evidence. Does anybody remember looking at these practice guidelines? Yeah, were you impressed?
I was impressed by how little there was.
Huh, you mean?
Yeah.
So full thickness tears and symptomatic patients. Rotator cuff repair is an option for patients with chronic symptomatic full thickness tears. What was the evidence to support that? Weak.
And I think a couple were only consensus by the panel.
Yeah, I just pulled out a couple. I didn't want to bore you too much. Acute, now we all agree that if I fall down and I can't raise my arm, then that'd be a good candidate for a rotator cuff repair, right? I would even say that. So, but here they looked at the evidence. Early surgical repair after acute injury is an option for patients, and the evidence for it being an option is weak. And then you have this other stuff. You know that I'm addicted to this blog. If you want to find it, you just have to Google shoulder blog and you come up with this. And one of the recurrent themes is, does integrity matter? I'm not talking about your honesty here. I'm talking about the intactness of a rotator cuff after a repair. I mean, that's why you do a repair, right? So this is just one of many, many studies that said that 75% of re-tears, so they had a high re-tear rate, right? 20%. And then you looked at 75% of the re-tears were identified within 6 months, and 25% were identified more than a year after. The functional outcomes of the intact group and the re-tear group were not different. Okay, so now we have a surgery for which there is weak evidence, and even if you do the surgery, it doesn't matter whether it works or not. And I sort of plotted their data here in the blog, and this is the improvement over time with intact repairs and re-tears. Now, I wouldn't call that a compelling difference, right? So there's a lot of argument in the literature about, do I use transosseous equivalents? Do I use single row, double row, triple row? How do I do it? But at least there's some evidence that it doesn't matter. So Are you telling me that we're spending $4 billion a year on a surgery supported by at least weak evidence that gives the same results whether it works or not? Somebody's going to ask this question sooner or later, right? And if we don't have the evidence for something, when we're trying to cut budgets, the things for which there's not evidence are likely to get.
So one thing about the last graph, though, is it's comparing people who retore and not compared to people who never had the surgery at all.
I know.
So there may be some effect from...
But the point is that the operation is called rotator cuff repair. And that means that the goal of it is to reestablish integrity of the rotator cuff. So the point is that if we're doing a comparison study about whether integrity matters, it doesn't seem to matter. Now, I'm not saying that the surgery doesn't help, but of course, you being the smart guy you are, would have a difficult time convincing me that if I did a sham operation on these people, we wouldn't have the same results. We just don't have the data. So, one of your favorites cartoons and mine is this one.
Yes.
So, do people make money off of doing rotator cuff repairs? These are called golden eggs here, right? And here's this goose ostrich with his head in the sand because he's not actually very interested about whether people are getting better or not. He's more interested about what's coming out of his hind end there. So it's just an interesting sort of thing. So my other question, and really what I wanted to focus on for the rest of this morning, is how much smarter would we be if we really looked at the results of the care of these people? Then we would really know what mattered. And so we can sort of have the lights up now, because I'm just going to, this is the last slide I'm going to put on, and I wanted to, Dan, maybe you go to the board here for a second. We're going to try to answer these questions, so leave some room for your subsequent thing. But can you all help me when you describe the result of treatment? What sort of things do you think of? How are you going to measure the result of treatment? You guys are going to have to help me, otherwise it's going to be a long morning.
Outcome measures.
Outcome measure. So what's an outcome measure? Like, give me an example of one.
The simple shoulder test.
Okay. We're going to measure that. Are you going to measure that? They're subjective and objective, so we can put those things down. What is a PRO?
Patient-reported outcome.
Very good. So how are you feeling about PROs versus, say, having my favorite therapist come and look at my patients?
I mean, I think that they're both important and for different reasons, but if part of the reason we're trying to do is to generate value, I think a lot of that value comes to how the patient feels they're doing after the surgery, and so PROs are very, very relevant, especially if they've been well validated in the population you're looking at. So
if you measure my strength, and if Brian measures my strength, are you going to necessarily get the same answer?
I would hope so, but
probably not, right? Because you each are going to do it differently. But if you each ask me to complete a PRO, the chances of it being the same are better. So we can keep that in mind. Somebody said improvement, and I think that's really important. So who said that?
Clinical improvement.
Clinical improvement. So how do you measure improvement?
Some of that can be objective strength testing. Some of it is subjective patient ADL function.
But how would you measure? We're talking about rotator cuff.
You need a variable for time.
Right.
You need a variable.
To see improvement.
So what would be a variables that you might use?
Range of motion.
Okay, so you could look at range of motion. And you could, and in order to measure the difference, you'd have to do what?
You have to have a standardized way of measuring it at different increments.
You'd have to measure it before and after treatment. And when we talk about improvement, we can call that delta. And so what's going to happen is that this is going to change with time, right? So it's a question as to how you make sure you collect those data and when you measure them. But it's going to be really important that you measure it in the same way, right? So if Jennifer measures it at one clinic visit and Dan measured is at another one, we haven't necessarily calibrated them. If I were a yardstick, you know, I'm hoping that we can measure them the same way. But I'm not really confident that we can measure range of motion in the same way. I remember when I was with Dr. Neer, he'd have everybody lie down on a table, and he'd take their arm and push it down until it was parallel with the table, and he'd say 180 degrees of forward elevation. Everybody got 180 degrees elevation after total shoulder. Even if they had to arch their back, they would still get 180 degrees. So this is important. So you have to, when you're measuring the difference, you have to measure it in the same way before and after. And certainly if you're trying to compare among centers, you have to be somehow convinced that it's being measured in the same way. And one of the challenges with like the constant score, which is used often, is that everybody measures strength in a different way. So this is another value of PROs, because hopefully patients are going to be more consistent among themselves. Now there's another kind of outcome that's used real commonly. These are what I would like to call improvement is an upside. What's another kind of outcome that people use?
Complications.
Pardon?
Complications.
Complications. So let's talk about outcomes that are positive outcomes, and then let's talk about negative outcomes. So complications. What's another kind of negative outcome?
Return to surgery.
Good. Reoperation. What else?
Cost.
Okay, we're going to get to cost in a minute, but we won't forget that you mentioned that. What's another one? What's the ultimate bad result?
Death.
Death. So a lot of these are all sort of things that are used, and when you look at many studies comparing different operations for different things, people look at reoperation rate, and sometimes they look at death. So we've got these sort of upsides and downsides. And other negative outcomes would be failure to heal, loosening of a prosthesis, failure of and all these sorts of things, loss of correction in a spine surgery. So there are a lot of negative kind of measures too. But if we're going to do this kind of clinical research, we're going to have to decide what is our primary outcome variable. What are we really going to be looking at? Because we can't look at all these different things. Otherwise it makes the math too complicated. So when you think about all these different tools, and we've got in the shoulder world and in the knee world and the hip world, and we have all sorts of different instruments for measuring these things, but you may want to think in your approach to clinical research as to whether or not you're focused on patient-reported outcomes or so-called objective outcomes. But the hazard, to say it again, with objective outcomes is beauty is in the eye of the beholder. And particularly if you're going to try to do multi-center studies, you know that it isn't necessarily the same. And when we tried to come up with scores for the American shoulder and elbow surgeons, we found that everybody measures the most simple thing, forward elevation, in totally different ways. Some people measure it sitting, some people measure it standing, some people measure it lying, some people measure elevation in the plane of the scapula, some people measure it forward, some people measure it to the side. And we had a whole room of really smart people, and none of them could agree on the most basic measurement, Jennifer says, is range of motion. You know, just absolutely 101. Couldn't do it. So it's frustrating. The second question is, how important is range of motion to the patient? Right? So when you measure a range of motion, you might get a number like 135 degrees after surgery and 100 degrees before. Did that really result in any important improvement in the function of that patient or not? The wonderful thing about a range of motion is a parametric variable, right? We plot it on a graph, and Kash and I were talking earlier about statistics for comparing these things. So the idea is with a linear variable like range of motion, you get to think that improvement is always good. But if you improve my range of motion from 150 to 160 degrees, does that really change what I can do with my arm? So again, my advice to you is when you're thinking about designing clinical studies, you want to decide what's important. And the easiest way to do that is with, I think, something like a patient-reported outcome that measures their impression of what they can do. Because if you say, gee, you've got great range of motion, great strength, you should be able to do all these things, and they still can't, does it really matter? So what we've talked about is downside or negative outcomes. We've talked about upside ones, and we've pointed out that in order to look at the benefit of our surgery, we need to look at the delta. And you'd be impressed with how many people talk about doing outcomes, but they don't have the data on how the patient was before the intervention. And you see papers like this all the time where they report people's scores on whatever metric after surgery, but they don't have what they were beforehand. Go ahead and take a seat. We'll get somebody else to be here. You've done a fine job. So,
Rick, could I ask you about the bias in patient-reported outcomes?
Sure.
Being a proponent of activity monitoring and monitoring patients in their own environment, I often think that there's a tendency of the patients to give you the answers on PROs that you want to hear. And do you think that there's a place for ambulatory monitoring to supplement or validate the patient's opinion of how they do?
it would be the best, because then you could assure the Brian versus whoever else I picked on problem. In other words, if you could be sure that the activity monitor was placed in the same way and gave similar results, and that you had normalized the tool. But activity monitors to me are another metric, and you just have to be sure that it's being applied the same way across the country if that's what you're interested in doing. You're totally correct, and if we had easy measures like that, it would be wonderful. And if we decided that our primary goal with shoulders, for example, was to have people using their arm a lot, then an activity monitor would be sensational. The question is, we need to make sure that there's not a problem with whether it's applied here, or when it's being worn, or who's applying it, or who agrees to use it. So it's sort of like offsetting penalties. I mean, there are good things and bad things about every method. But the nice thing about patient-reported outcomes is that, again, you can assume that it's the same tool, it stays the same. Now, whether people are answering it to please you or not is a different question, and that has to do with who's applying the test, who looks at the results, and whether the surgeon's indeed going to be involved or not. But I think it's a very valid point.
And one way people have tried to get around that is most of them are now validated for people to do it on the internet, which is actually very convenient, and people doing it at home, before they get to clinic.
Yep. So all these are questions that you ought to think about as you're trying to measure the efficacy of your treatments, the treatments you want to continue to be able to do. Now, when we talk about improvement, the question is, how do we really measure improvement, or how do we talk about it? So let's just take a scale, and we'll take the SST for example, since it's one I'm familiar with. So you have 100% function, and you have 0% function. And I would submit to you that most PROs instruments are methods of measuring how close you are to being normal. Full scale is 100%, 0 is I can't do anything. So whether you're talking about the SF36 or talking about the Harris-Hip score or anything else, there's a bottom and there's a top. And so you can normalize all these scales to 0 to 100. Now before surgery, my patient is here. And after surgery, my patient is here. So if you're writing this up, I'll put a number here. We'll say this is 50 and this is 73. So how am I going to report out that amount of improvement? Andrew, do you have an idea?
Well, you can report the 23% increase in SST, or just the raw score increase.
Okay, so let's think about that. So is that improvement, which you say is 23, the same as an improvement from 0 to 23?
Right, I mean, it's not. That's the thing. I mean, there's different ways to present the data, and they can look at different ways. You can present it as a percentage of increase relative to what they started with, or
yeah. So there are lots of different ways. So tell me. So you said I could say.
Well, I mean,
Go ahead. You were going to tell me that I could say how much improved I am, so you divide 50 into 73, and that's how much better I was?
Yeah, or you can say you improved 23 over 50, or you can say that the top scoring person was 90, so we increased relative to 90 rather than relative to 100, or whatever, however you want to do it.
The point is it's difficult, isn't it? Because, so some people would just report the 73. These are the people that report the outcome but don't report where you started. Then there are people that report this and this, and then there's all sorts of different percents. Brian, what do you think the best way to do it is?
So, I mean, I was trying to feed Andrew. This is out of our paper where if I can get 50% better, I want to know how much of my 50% better I got. So the guy who started at 0 and he improved 23% out of 100%, whereas the guy who went from 50 to 73 got 23 out of 50%. So as a ratio of the total capacity for improvement.
I don't know that there's a right or wrong here, but I think it's important that you think about it as you read papers and as you do your own research. I mean, what does better mean? And how do you measure how much better somebody is? So what Dr. Gilmer said is one way to look at this is that this guy had the potential for improving 50 points. He improved 23. So he had a 46% of the maximum possible improvement. So that's one way to do it. Now there's all sorts of other ways to do it. What does this mean? What is that?
Minimal clinically important difference.
What the heck is that?
Well, there's multiple ways to calculate it, but the idea is how big of a difference do you need for something which we could all agree is a clinically relevant difference. So maybe someone would say if you went from 50 to 52, yeah, and if the p-value was 0.00001, you'd go, great, statistically significant improvement, but does that matter to the patient? And there are different ways of doing it. There's anchor-based, there's distribution-based, there's a lot of different math ways of trying to figure out.
So somebody said that the improvement in the simple shoulder test is 2 to 3. So we'll say that that's this much improvement on this full scale. Now, does it matter to you whether that improvement is here or here? You know, this patient may not be quite as pleased as this patient. The patient right here that improves the same amount may be really improved because they're sort of on the steep part of the curve. So they may not be able to do everything, but they can do a heck of a lot more.
Well, one thing I'd like to know is what an age-matched or something-matched normal person's score is. So, you know, what percentage of people kind of move into the normal range?
So all I'm trying to point out is that we need to make the decision on the metric we're going to use, and then we need to make a decision about how we're going to categorize the improvement. And we also have to be careful that we know what we're measuring. As Peter Kavanaugh said, we want to make sure we're not measuring the patient's love for us, right? Dr. Hansen's patients all love him, and if you ask them, are you better? They'll say, of course, Dr. Hansen, I'm better. Would you have the operation again? If you do it, I'd do it 100, you know? So you just have to be careful that you know what you're measuring. But as Brian says, one of the ways to look at this is the percentage of the distance to the goal line that you got with that play. And at least that has a way of letting you know ultimately how much better the patient was in relation to how much they could have possibly gotten better, which is what we're doing this for. And if the patient was headed for this goal line and only got a small percentage of the way there, that was not as valuable as somebody who went a large way to the goal line. Now, the next thing is, when after treatment do you measure this? We've had a recent example of a negative outcome related to metal-on-metal hits, right? Now, the journal wanted, what is the length of follow-up the journal wants for an adult reconstruction paper before they'll accept it?
2 years.
2 years. How many metal-on-metal hips failed at 2 years?
59%.
A small percent. How many of them failed at 6 years? A lot. So I could get all my metal-on-metal hip papers published without problem, and my results would be great. I met the standard. Same thing when I showed you the rotator cuff results. The integrity of the rotator cuff goes down with time. So it matters when you measure this outcome. Now, in a recent paper that we put together, we thought that looking at these negative things, a nice way to talk about it, who said reoperation? So the interesting thing to think about is reoperations per year. Because you'll see some papers that will report a 50% complication rate because they had 10 years of follow-up, and some that had a 5% complication rate that just followed them for a year. So obviously I want to go to the doctor that did the 5% complication rate, except for the fact that the results are really the same. So what you really want to know is, how did these things change over time? That has to do with the durability of the result. And if you look at, again, I pulled a recent paper that said that the British group that had metal-on-metal hips 5 years ago, the failure rate was 3%, but the ones that had them 6 years ago, it was 5%. And who knows what it'll be at 10, 15, and 20 years. So it does matter. So when you're thinking about doing outcome research, just to recapitulate, we have to think about the metric. And your research is going to be a lot easier always if you come up with a primary outcome variable. Otherwise, your math is going to be really tough. You could always use secondary things, but you really want to find out what result you really care about. You have to decide how you're going to measure it, and you're going to have to decide how you're going to characterize the improvement, as we talked about. And you're going to have to talk about how you're going to record that improvement over time. Cortisone shots for a shoulder may do this. Other results may get better with time. So just think about those things as you're trying to collect these data. Because as my original slide showed out, this is going to be really important to your future. Because otherwise what's going to happen is the government's just going to progressively cut the value for everything. And there's going to be, because that's politically easier, right? We're just going to make cross-the-board cuts. But what we can do is we can sort of say, how can we do a good job of looking at what we're doing and showing how effective it is? But we're going to have to come up with a robust kind of methodology that will be convincing. So not only do I have to convince you of what this way is, but you have to be able to convince Congress or insurance companies or whoever that you've got a way of expressing the data that matters. When you look at, for example, one of the papers we're working on is first, second, third, fourth generation total shoulders. Are the results any better? I think you already know what the answer to that question is going to be. But it turns out that the easiest way to measure that, if you look at the publications that are out there, is reoperation rate. And so any number you want, just make sure it's something that's going to make sense to people who are listening to you. Ted, I'm sorry.
Oh, well, you can finish here.
No,
I have a question about if perhaps the length of time that you're following, or if you're answering a question, is that, and having good research, for example, if you have research where you wait 6 years before you report your results, is that in line with incentives for academic physicians who need to publish more papers? So if you kind of hold this paper in the wings while you get your follow-up, well, then you're not meeting whatever requirements you are by your university to publish, these papers. So it's, I want to publish 2 papers in that time.
Yep.
Because it's going to, I don't know how you get around that.
I wasn't implying that one should wait to publish. I was just saying that you have to, in your, my favorite part in every paper is the limitations section, right? Anybody read those? Mm-hmm. This paper has to be understood in line of certain limitations. And there you find out whether Ted Souza is really shooting straight with you about what he did. And so if he's reporting fabulous 2-year outcomes for metal-on-metal hips, you want him to say there, I'm doing this so I can be promoted, but the real story is that things may happen in the next years that are different than what I'm reporting here. So that, to me, is the best way to do it. I mean, you just want to be honest, and you say, the results that I got have to do with this section of patients, and this has to do with the operation I did, and this is the way I measured it, and these are the results at 2 years. And I think that way people can understand that.
Rick, what are the shortest follow-ups that journals in your field will take these days?
Well, so for reconstructive procedures, whatever those are, they require 2 years. But we mentioned while you were out of the room that in the metal-on-metal hips, you wouldn't have known that there was a problem in 2 years, and that's Ted's point, or in 4 years. You'll really only know it at 5, 6, or 7 years.
Right.
So as long as you report it for what it is, I think you're fine. And again, going back to what is the, when Dr. Jacobs, Josh Jacobs, right? Is he the guy that's writing on this? On metal-on-metal failure? We had him here as a guest professor. Remember him from Rush? No? No one remembers that? Anyway, he's the guy who's sort of taken the cover off the metal-on-metal stuff. And so what he's using as a metric is reoperations. And he's looking at reoperations per time. So, now we're going to shift to a different topic, and so you can erase all that up there, Andrew. We can start all over again. One of the things that we want to know, and I don't know if you read that little article that I gave you. It was long, but I thought that it was really interesting, this particular quote from it, because it has to do with the sample that we're taking. So Emily, can you read that from where you are?
Yeah.
Read it out loud for us.
What is worse, the glitter of the table diverts attention from the inadequacies of the fair. Only a tithe and an unknown tithe of the factory personnel volunteer for some procedure or interview. 20% of patients treated in some particular way are lost to sight. 30% of a randomly drawn sample are never contacted. The sample may indeed be akin to that of a man who had a mind to sell his house and carried a piece of brick in his pocket, which he showed as a pattern to encourage purchasers.
So the point is that the sample you take is really important, and it's all too easy to find a reason to exclude the people that didn't quite measure up because they were labor and injuries, or they were male, or because of we didn't have adequate x-rays. I mean, so if you don't have adequate x-rays, that could mean either the x-ray showed a bad result or you didn't have an adequate x-ray. So you've got to be careful. And one of the things that, going back to the goose ostrich that you're aware of, that Seth has pointed out over and over again, is that industrially funded research has a tendency to sort of lose the bad results. And if you remember the articles by Carnegie having to do with the BMP, any potential spine surgeons in here? No spine surgeons? Dr. Chapman was so disappointed. Anyway, do you remember the BMP controversy in spine fusion? So the first 14 papers that were published were industry funded, and the complication rate was 0. And then all of a sudden you had a bunch of NIH funded stuff where you had all sorts of bad things happening. So you can come to your own conclusion about what went on there, but it could be that we accidentally lost some of the people. And one of the things you have to always decide when you're reading a paper is, does that patient population, is that representative of the kind of people that we're all treating? For example, in a randomized controlled study, how many of you would be prepared to have your prostate cancer, I'll leave the women out of this, treated according to a random assigned variable between radiation and radical prostatectomy? I would submit to you that only a certain kind of person is going to volunteer for that study. Now, this is going to be a level 1 study. It's going to get all the fancy reviews because it's a level 1 study. But a lot of people are going to sort of get to the moment and they're going to say, I'm not so sure. So the intention to treat analysis is going to go south on you and so on. So how many people really, I mean, I've got a cuff tear. Am I going to allow Nate to pull an envelope to decide if I get operated or not? So you have to ask yourself, are the patients that are in this study relevant? And you also have to ask, of all the people that the author could have potentially enrolled, how many of them actually did get enrolled, because otherwise you have this problem. Does that make sense to anybody? So look at the patient population and say, is that the kind of people that we are interested in treating, and was there any selection? So now we're going to get to this, Dan. So now we've determined how we're going to talk about the result. We've determined the patient population we're going to look at. Now we want to talk about the factors that affect it. And I'm going to suggest to you there are 4 P's that you should leave this room remembering. But rather than guessing what the 4 P's are, what are some of the factors that would influence the result of the treatment of a condition?
Patient.
The patient. Very good. That starts with P. Now, tell me some things about the patient that would be of interest to you. That matter, the things that matter.
Preoperative status. Preoperative
Like what?
Function.
Pardon?
Preoperative function.
So, okay, so let's write the function. We'll say the preoperative comfort and function. The most important variable in predicting pain after total knee arthroplasty is?
Preoperative pain.
Preoperative pain. Better start with that, right? So comfort and function, let's put comfort along there. What else about the patient?
Past medical history.
Well, more specific, what?
Comorbidities like smoking.
Smoking, good. Let's put smoking down there. What else?
Narcotics.
LNI.
Labor and industry status. These are all patient variables. It has nothing to do with whether you're doing a spine fusion or a bunion, right? This is just general stuff. What's just some others, just for fun?
Narcotics.
Narcotics.
Psychiatric disease.
Depression, number 1 thing. What else? You've left out 2 biggies.
How rich they are.
Well, okay, insurance coverage. Yeah. What else? The most 2 really important things.
They have a job.
What's the difference between you and me? Age, good. What's the difference between you and Emily? Gender, good. You guys are really on it this morning. That's good. I won't ask you how you know. So, but it is true. It is true that women report differently on PROs than guys do.
We're whiners.
Pardon?
We're whiners.
No.
It's the opposite.
My theory is, so who's more likely to ask for directions when they're lost? I mean, so I always think that it's women are more comfortable telling it like it is. I'm lost. How do I get out of this? Guys saying, I'm not lost. I'm just temporarily bewildered. You know, and so I think that it's really important to understand that we're all for equity and stuff, but it's not the same. It's not the same. And people respond, genders respond differently. Old people respond differently. Old people have different diseases. We did a paper that compared patients that had arthritis under and over 50, and guess what? Totally different set of people, totally different set of diagnoses. So I'm happy that you started out with a patient. So you can come up with another thing, but when you're doing your analysis, you have to be sure and include some of these things, particularly the ones that you think are really important. And unless you start collecting those data at the beginning, it's going to be harder to get at some of these things at the end. What's another P?
Procedure.
The procedure, okay? So tell me about the procedure. What does that mean? That means, did we do
The same thing in everyone, were there associated procedures that went with the primary procedure?
Did we nail it or did we plate it? Did we use an anterior approach or a posterior approach? What implant did we use? Did we use a Zimmer or a Synthes? All those sorts of things are important as parts of the procedure. And there are other things that are there, like the rehab that we did afterwards. That's part of the procedure too. So all these things can affect the result. So what's another P? What's another thing that's important to you?
Physician or the provider?
Very good. You guys, very good. The provider. So does it matter if I'm doing a total ankle or Dr. Hansen is doing it? It matters to the patient for sure, right? Now, what is it that makes Dr. Hansen different than me doing a total ankle? volume of these cases that he's done. What else? Well, because he does a lot of them, he's got a team around him that does them all the time. Scrub nurses, the residents, fellows, everybody know what he's doing, so he's got this team. Everything is sort of wired around it. But what else do you get from somebody who's done a lot of cases? What are some other things that happen if you're an experienced surgeon?
Faster.
Faster. What else? Judgment about who to do it on. That's one of the most important things is, I mean, total ankle could be done on anybody. The question is, who are the right people for it? So the patient selection is really, really important, I think, as a part of the procedure, the provider that goes into this. And so I like to say, you know, the surgeon is the method, because a lot of people want to compare total ankles to ankle fusions, for example, or they want to compare fixation to prostheses for proximal humeral fractures. But the problem is, if we're going to try to do a study like that, it's rare to find people who are equally versed in doing both. So these volume effects have to be considered, I think. So there's one more P, and that's what the problem is. So all tibial fractures are not the same, so we have to find a way of characterizing what we're treating. Acute versus chronic rotator cuffs, amount of retraction, amount of comminution of a fracture, the degree of curvature, and all that sort of thing. So to me, these are the 4 Ps that you want to think about in characterizing the characterizing what I like to call the end goal. In other words, this is what goes into the treatment here. And I'm happy that you mentioned this, because if you're going to use patient-reported outcomes, this is going to be your baseline. But it can also be of predictive value. In other words, if you use like the SF-36, it's got a lot of measures of socialization and general physical activity, sort of the patient's self-assessment of Dr. Kavanaugh's activity monitor. And a lot of those things turn out to be predictive of how well a patient does. So if you've got somebody who's socializing and has family support and is not depressed and has not been sad or blue a lot recently, they're going to have a much better chance of getting better than somebody who answers no to all those questions. So all this stuff is going to affect how well a patient does, don't you think? And so you want to get a handle on some of these things. And if you're not, it doesn't mean you need to measure them all. It just means you need to think about them all beforehand. You need to think about how these things might affect the result. And that's why I'm so pleased that you know the answer to the question about the prediction of total knee pain after surgery. That has to do with, on this whole page, it certainly doesn't have to do with whether you use a Zimmer or a Helmetica knee, or whether you use a rotating platform or not, or whether you do a patelectomy or not. It has to do with that. So if your primary outcome variable is the VAS pain scale, you sure better have a handle on that. So to me, these are all the variables that you want to include in thinking about about your clinical research, is things that you want to at least potentially measure about your patients and figure out a systematic way to collect them. And I think that for a department like ours, we want to make sure that the medical record contains as much of this stuff as possible automatically, because that's things we ought to be considering in our decision making about the patient. So then the question is, now you've got our primary outcome variable, which we'll say is the percent of improvement over the maximum improvement, and we're going to, whatever scale you want to use for that. And now we've got all these variables. So this is the independent variable, and these are all the potentially dependent variables. So how do you do the math? What sort of statistical tools do you use? Jacques, do you have an idea?
Yeah, like Paige just said, statistician. And then it's t-tests and means and standard deviation. Is that what you were going for?
Well, you sort of threw the book at me there. Let's just say. So let's say that we are looking at age versus this. So what do we look at? What kind of analysis do we do for comparing two parametric variables?
ANOVA?
Just two.
Well, there are a number of things that you can use. Remember, when you're comparing, what is this going to look like if I plot improvement versus age? It's going to look like what kind of a plot?
A line.
Begins with S.
Scatter.
Okay, so how do you make sense out of that?
Linear regression.
Very good.
Continuous variable.
So you draw a line and you look at some things that are called Pearson's correlation coefficient and so on. But you basically do what are called univariate statistics. So you're going to go through each one of these things, and if they're categorical variables like gender, you use one set of tests. If there are parametric variables, then you'll use something that compares two different parametric variables. And you're talking about a t-test. When do you use a t-test?
Continuous data, parametric, two groups.
Two groups, which means you have a categorical variable versus a continuous variable, right? So you have men versus women, and that's where you use a t-test. Or you could use a t-test for comparing before and after. What kind of t-test would that be?
Students.
No.
Oh.
Yeah. I heard it.
Paired.
Paired. That's a paired t-test. What about comparing gals and guys? What kind of t-test is that? What's the opposite of paired? I don't want to make this too hard. Unpaired. Very good, right? Okay, so what you do is this is an unpaired t-test where you compare these two groups. It's not the same as comparing before and after, because every before has an after and every after has a before. As we all know, for the number of single people in the world, every woman and man do not exist as a pair, right? So you're going to do an unpaired t-test. But regardless of what you're doing, you have to use some sort of univariate statistics. And then you're going to come up with ones that look tempting versus ones you can toss out. So it turns out that income doesn't matter. So we can toss that out. And then what we have to do is another kind of statistics. And what's the broad name for what we need to do now that we've decided which variables look like they're possibly important? What do we do then? Multivariable statistics, right? And there are various ways of doing that with forward and backward inclusions and so on, and we don't need to go through the details, but the idea is you have to figure out some way of prioritizing which of these variables are most important, because what you'd like to do is to understand which of all these factors are going to be most predictive of the outcome. Because that's the goal, because you'd like to be able to say, okay, my patient has this value, this value, this value, this value on those factors. I know who I am, and I know what the problem is. They've got a Schatzker whatever type fracture, and I know what the different procedures are that I'm considering. And so then I can ask, based on the data that I have, what is most predictive of the outcome that I want. So just remember that when you have all these variables, you have to get rid of a lot of them. Those steps are, I do univariate statistics for finding out ones that have tempting correlation coefficients or tempting p-values. So people will often use something like a 0.1 or 0.2 for inclusion in the model, and then you'll do a multivariate regression to find out which ones are most important. And the reason multivariate is important is if you look at, let's say one of my variables is female gender, one is BMI, one is whether they're diabetic or not, and another one is how much insulin they're taking. We think about all those things, and those may or may not be totally independent. right? So what your multivariate statistics do is enable you to figure out which one of those is most important and tosses out the ones that are less. So the last thing I want to talk about is value. And so can anybody come up with a definition of value in this context for us? Because that's what the government wants to know, is what procedures are of most value.
Effectiveness over cost.
Say it a little louder.
Effectiveness over cost.
Effectiveness over cost, okay. So we've spent a lot of time talking about effectiveness, right? Now tell me what do you mean by cost?
Well, I mean, it means things earlier like the total cost. In other words, like time lost from work, and not just sort of the cost of the surgery and the implants.
Time lost, the surgeon and the hospital, rehab, implant, we've got that already. And time is equal to money, so we can convert that. What are some other things that are important? Things that are usually not considered in clinical research but are still part of the cost.
Time away from work.
Okay, we sort of got this here.
Other options?
So, Kofi Annan, anybody know Kofi Annan? Anyway, Kofi Annan gave a graduation speech to one of my kids' colleges, and he said, let's talk about the cost of nuclear energy. And so he said, you know, the cost of nuclear energy can be thought about the cost of producing a kilowatt hour. But in order to include a total picture of the cost, what else do you have to include?
Long-term effects of a nuclear meltdown, or
you have to include the Chernobyl effect, right? So it's the cost of waste disposal, it's the cost of a meltdown, as well as the cost of building the thing and generating the power. And when people talk about the cost, they just sort of want to talk about, you know, how cheap it is to provide nuclear energy, but they don't want to talk about these other things. But this has to go into the equation. So what is the equivalent here? The cost of what?
Reoperation.
Cost of failure, the cost of reoperations. So when people talk about the value of surgery, they often do not include this, and they talk often about the patients that did better, the patients that didn't need to be revised, and so on. But when you have something that has a, as we were saying earlier, a 6% or whatever revision rate, that has to go into the cost of the procedure. And so when I'm making a decision about my rotator cuff management, I'm sort of saying, well, you know, I've got the cost of time loss, I've got the cost of the surgeon, the hospital, maybe not too many implants, although knowing some people that have 50 anchors in there, cost of the rehab. Time loss is going to be important, for me anyway. And what if it fails? Then I've got a bunch of sutures floating around inside my shoulder, some prominent suture anchors and all that sort of stuff. And I may have to have another operation. So I have to include the odds of those things happening in my estimate of the total cost. So that's pretty much what I want to share with you. I appreciate your kind attention for that. I just want to let you know that clinical research is the most important kind of research we can do. As David Ayre said when he came on as our first endowed professor, he said, clinical research is really hard. That's why I'm doing basic research. And he's right. It is really hard to do good clinical research. But at least today, I've tried to convince you of the importance of doing it, because it has a lot to do with your survival in the field, and some of the things that you need to think about as you go about reading it, and as you go about thinking about doing it. Thank you very much.
Thanks so much for taking